So today we're going to, as I said, we're going to focus on the truth about HRT, dispel myths, and we'll also talk about non-hormonal alternatives to HRT, and then I hope there'll be time for questions. Well, there will be time for questions. What I would say is that obviously the advice that I give is as accurate as possible, but it is general advice, not a substitute for if you've got any particular individualized questions. It's not a substitute for seeing your own GP or healthcare practitioner. And as has been said, the talk is being recorded, so just be aware of that when you're asking questions. That you maybe word them in a way that's sort of so that they're sort of generalized rather than personalized, just for your own protection. Okay, so what I'm going to do, I did a quiz last time. I don't know what you thought of it, those of you who were here, but I have done another little quiz, so it's I just want to put it up. So what I'm going to do is I'm going to put the link to the quiz in the chat. So it's just 3 questions. It's just supposed to be a bit of fun. It's not supposed to put anybody on the spot. Just to and it sort of make it hopefully hopefully a little bit of extra interaction. So I've just got to get the link. Just got to copy the link, and then I've got to paste it into the chat. Meeting chat. So how do I chat? Oh, I can't see. So hopefully that gives a little bit of background fun. Okay, so let's go straight on to talking about hormone replacement therapy. So hormone replacement therapy, the active ingredient is estrogen. So it's a physiological and natural amount of estrogen, and that's what helps with the symptoms that we'll go on to in a bit. And there's various different ways that you can take estrogen. You can take it orally as a daily tablet, or you can take it transdermally, either as a patch, either used twice weekly or weekly, or as a gel applied every day to the shoulders, inner thighs, or even now there's a spray which you apply to the forearm here. So that's how estrogen is given. And then, so when HRT was developed in the 40s, it just contained estrogen, and throughout the 50s and 60s, HRT, when it was prescribed, was just given as estrogen. However, lots of studies started to be done, and in 1975, studies began to show that without adding a progestogen, if in women who have a uterus, without adding a progestogen, that unopposed estrogen therapy resulted in an 8-fold increase in the risk of endometrial cancer. And then they discovered that adding a progestogen to HRT reduced that risk of endometrial cancer. So anyone who takes HRT who's got a uterus should generally take combined HRT. And there's 2 types of combined HRT. There's cyclical combined HRT, which is where you have a monthly period and you take the estrogen all the time. You take the progestogen for 2 weeks out of every 4. Although there is one type that's long cycle where you have the progestogen once every 3 months. But that's suitable. So it's cyclical combined is suitable for women when they're still having periods, and it can be given in tablet or patch form, vaginal gel with the estrogen. And then for women who've are further through their menopause transition, whose periods have stopped more than a year, or who are sort of age 54 or above, then they can take continuous combined HRT, which is designed to be period free. And that can be given in a combination of tablets, patches, vaginal gel, and the Mirena intrauterine system, which we'll come on to in a bit. So the benefits of HRT, well, it's very good at reducing flushes and sweats. It is 99% effective for that. And it can also improve the low mood and that can be associated with the menopause as well. And muscle and joint pains that some people get. And it also reduces bladder and vaginal symptoms, what we call genitourinary syndrome of the menopause, where the lack of stimulation of the estrogen receptors can cause a lot of urgency, urinary urgency, and vaginal dryness and discomfort. So it can also improve sexual problems, although we'll come on to later that sometimes people take testosterone as well, and or vaginal estrogen. And overall, it improves quality of life. There's other sort of more hidden effects. So it maintains the strength of the bones. It stops, the loss of bone mineralization that occurs after the menopause. So it reduces fracture risk, and it maintains muscle mass and strength. And studies are now beginning to show that certainly if you take HRT within 10 years of the menopause, that there's a reduced risk of cardiovascular problems. Women start to catch men up after the menopause in terms of cardiovascular risk, and certainly women who go through an early menopause do have a higher risk of cardiovascular problems. So we're talking arterial heart attacks. So it's very beneficial, particularly for women who have an early menopause. It also reverses what we call the metabolic syndrome, which is a syndrome where sort of weight gain, cholesterol, impaired glucose tolerance. So it can reduce the risk of developing diabetes. It alters a pre-diabetic state. And combined HRT has been shown to slightly reduce the risk of bowel cancer as well. Oh, somebody's saying their slides aren't moving on. Is it just one person, or is there anybody else having problems with the slides moving on?
No, so my slides haven't moved on.
Oh.
If you click on the top, there's 8 slide 8 out of 30. So if it does stop, sometimes it stopped for me, but I'll keep a note on the chat as well.
Yeah. Oh, yeah. So we're on 8 out of 30. So I'll just give you a minute just to catch up because I don't want you to miss out on.
A lot of people are okay.
All right. Brilliant. Yeah.
Thank you.
Okay, fantastic. So when HRT was originally discovered and designed, the estrogen in it is what we call conjugated equine estrogens. So it basically comes from pregnant mare urine. And horse welfare has been in the news over the last couple of days. So this is a picture of a horse farm where they impregnate the mares, and you might be able to see that they're sort of wearing a contraption that collects their urine. They're stood in quite close stalls. There's no natural light in there. Don't ask me any more about the welfare because I don't know whether they have to stay in those throughout the whole 24 hours or whether they are moved at all. But I just thought you should be aware that that's where the source of conjugated equine estrogens, and they are still used in one particular brand of HRT, an oral brand called Premarin. So Premarin is actually short for pregnant mare's urine. So there you go. But much more recently, a lot more forms of HRT are now synthesized from plants, so soy and yams, and the products that are synthesized, the chemicals that are extracted, the hormones that are extracted, are then synthesized into what we call body identical hormones. So the three human estrogens are estradiol, estrone, and estriol. And in most HRTs we use estradiol, and that is body identical. Okay. And also more recently, there's also micronized progesterone, which we'll come on to a bit more, is body identical progesterone as well. It's exactly the same as the progesterone that's in women's, that we produce naturally in our bodies. Okay, there are some synthetic progestogens used in some HRTs as well, which can be very helpful, particularly for women who have maybe bleeding problems on certain brands of HRT. Finding the right HRT is a bit like finding the right contraceptive pill, that there's lots of different brands, and many people will be quite happy on the first brand that they try, but some people have to try a couple of different brands to find one that suits them. So sometimes synthetic progestogens can be really helpful, yes, sort of for bleeding problems. And on the left there's a picture of the Mirena coil, which can, as well as it's a contraceptive coil that releases levonorgestrel, which is a synthetic progestogen. It releases it very slowly into the lining of the womb, and it's very, very effective contraceptive. It lasts for five years, and it can also be used as the progestogen part of HRT, which can be very helpful, particularly if women who are still having periods want to aim for period-free HRT, because a lot of women who use the Mirena, their periods do get much lighter and they can stop altogether. And because not much of the hormone is makes it through into the bloodstream, side effects are minimal. Right, so has anybody got any particular questions just on that section, any points of clarification? Then we can do a bit of a more question section when we've turned the video off later.
Yeah, if anyone's got a question, you can either put your hand up or write it in the chat.
Oh,
Andrea. Hi, Andrea.
Hiya. I was just wondering, you say with the Mirena coil, that helps as part of the HRT treatment. How long would that remain in for?
Oh, I didn't quite catch, sorry, I didn't quite catch all of your question. I heard Mirena coil and I heard how long can it stay in for?
Yeah, as part of the combination. So I've just started HRT, so I've got a patch, the still patch, and the Mirena coil, that's in as well. So how long would that be sufficient for, do you think?
So the Mirena for HRT, the Mirena coil can be used for 5 years.
Just the fact, because I was told that it could stay in for 7.
It can stay in for 7 for contraception, but not for HRT.
Right, thank you.
Yeah, thank you, Andrea. Tracy's just put, what are the negatives of HRT?
Yeah, we're going to come on. That's the next section.
Brilliant. Okay. And then do some transdermal patches adhere to the skin better than others? The patches I have been given now seem less effective than my previous prescription.
Right, yeah, well, I mean, yeah, so patches, one of the issues with patches can be the stickiness. I mean, I think for most people they stick okay, although I have to say I've not seen any studies, but anecdotally I would say the ones that are twice weekly tend to stick on better and last better than the ones that are changed weekly. I have had, people, I've anecdotally I found that people that go on the weekly patch, some of them have to change it earlier, so it doesn't quite last a week actually, which can be a bit of a pain because it only comes in a pack of 4. But there are lots of different patches, so it's worth, if one doesn't suit, it is really worth asking for a different patch to see if that sticks on better, because they are all different sizes. Personally, I have actually used three out of the 4 different patches that are available, because a couple of years ago there was a problem with supply of different patches, so I end up going through quite a few different patches. And I would say I sort of did have a bit of a personal preference, but I think the thing is it's going to be individual for different people. The other thing is to make sure that you don't that the skin that you stick it onto isn't going to get rubbed by clothing. And some people use like baby oil to take because it's a bit like a plaster, it leaves a little tiny residue afterwards. So baby oil is really good for getting that off. But the trouble is, if you then stick a patch onto the baby oil skin, it's not going to stick very well. So you need to make sure it's stuck onto nice dry skin.
Real, thank you.
Okay.
Just a couple more, and then I think we'll probably be able to move on.
Yep.
I've got the Mirena coil to help with my periods, and I'm now experiencing menopausal symptoms. Is it possible I need an estrogen support? I'm waiting to speak to my GP. So
somebody who's got a Mirena in and it's controlling their periods, then if they wanted to, yes, they could. If they were getting troublesome menopausal symptoms and they felt that they needed some support with those symptoms, then yes, it's possible to take estrogen. And so you have the estrogen bit that helps with the menopause symptoms, and then you have the Mirena. You use the Mirena to protect the lining of the womb to prevent against endometrial cancer. And you can use the Mirena, has to be changed every 5 years.
Right. Okay. And then just one more, I think, looking at it. Oh, I might get a few more, but I might just leave those to later. What are the benefits and detriments of estrogen-only HRT for ladies following a full hysterectomy?
Absolutely the same. So the benefits are the same as what we've just mentioned, all of those. And if you've had a hysterectomy, you don't need to worry about any risk of endometrial cancer, and so you don't have to take the progestogen part. Well, most people don't. Certain conditions, maybe endometriosis, sometimes the gynecologist asks people to use progestogen for a little while, but that's getting quite specialized. But generally, if you're estrogen only HRT, you've got all the benefits, and we'll come on to the risks just now. But certainly, if generally speaking, if HRT is going to cause any side effects, it tends to be the progestogen part of HRT that is more likely to be causing the side effects. So all that problem is not relevant to somebody who's had a hysterectomy. So it can be good. It's one benefit, shall we say, of having a hysterectomy, that you only have to take estrogen only HRT.
Okay. One last one then is at what stage should HRT be started?
Well, yeah, good question. I mean, when symptoms are severe enough that I think it's affecting people's quality of life, and they feel that they need it to help them to help with their personal, professional, social well-being, I would say. There's no hard and fast rule really about when HRT should be started, but a lot of women start HRT when they're still having periods, because often that can be when the symptoms are at their most severe.
Real, thank you. Shall I save the rest of the questions?
Yeah, shall we move on? Yeah, okay, brilliant. So we'll come onto safety of HRT. And so over the last 4 decades, we went from the euphoria of the 1990s to the panic of the noughties, when the Million Women and Women's Health Initiative studies came out, and it was all like lots of headlines about the risks of breast cancer, etc., etc. But now that we've got more studies available, we had the NICE guidance in 2015, and there's very good guidance from the British Menopause Society, American Menopause Society, Royal Osteoporosis Association, and the Endocrine Society. The problem is that a generation of doctors have qualified with textbooks that still have got the Million Women study and the Women's Health Initiative study in them. And the other thing about general practice is, through no fault of the staff, is that it's designed where you have 10-minute appointments, and it is very difficult to get to talk about all your concerns and the pros and cons of HRT in 10 minutes. It's impossible, really. And so often people can go away sort of feeling like they're asked to sort of look into alternatives, etc., and maybe feel that their GP's against HRT, which may or may not be true, really, because it may be that just the limitations of the 10-minute appointment might be contributing there. So in terms of risks, there is a small increased risk of deep vein thrombosis. That means blood clots on the leg or lungs. So there is a background risk. We've all got a risk of age 50 to 59. The background risk is 1 in 1,000. And on oral HRT, tablet HRT, so estrogen combined with progestogen, the risk doubles to 2 per 1,000 per year. Okay, so the estrogen only HRT possibly has a slightly lower risk. Combined HRT with certain types of progestogen, so digestogenone's one, and then natural micronized body identical progesterone, it's thought that they might have a lower risk of deep vein thrombosis. And the other thing to bear in mind is that the risk of deep vein thrombosis only refers to oral HRT, because transdermal HRT, transdermal estrogen, doesn't increase the risk of deep vein thrombosis. And likewise with stroke, there's a very small increased risk of stroke if you take oral HRT. So the background risk for us, for somebody like of my age, I'm 56, so my background risk is 4 per 1,000, and if I was to take oral HRT, it would go up to 5 per 1,000 if I took oral HRT for 5 years. And again, certain types of progesterone are thought to be safer, digesterone and micronized body identical progesterone, and also transdermal HRT doesn't increase the risk of stroke. Now, I put this up because it's one that I don't think people often hear about with HRT, but anything that's got estrogen in, so being pregnant increases your risk of having gallbladder problems, and so does the contraceptive pill, and so does HRT does increase the risk of having symptomatic gallbladder disease. 10 to 15% of the population have gallstones, and 1 in 3 of those get symptoms, and it is more common in middle-aged women with higher levels of estrogen, and after dieting as well is another risk factor for gallbladder disease. Okay, and so in terms of ovarian cancer, there's the background risk per year is 4 per 1,000. The studies do vary in conclusion, but there might be a very slight increased risk. And we talked about cancer of the lining of the womb. The background risk is 5 per 1,000 per year. So if you take cyclical combined, that's where you have a period once a month or once every 3 months, or a synthetic form of HRT called tibolone, there's a very, very slight increased risk over baseline. But if you take continuous combined, that's period-free HRT, then there's a reduced risk of cancer of the lining of the womb. And obviously, if you've had a hysterectomy and you take an estrogen-only HRT, then you don't need to worry about cancer of the lining of the womb. And if you've had your ovaries removed as well, you don't need to worry about ovarian cancer. Okay, so we'll come on to breast cancer then. So I'm going to present the breast cancer studies. I hope this isn't a bit too technical. I will give you a chance to ask questions after this little section. So I'm going to put it in different ways. So this is some figures about what we call absolute risk. So it's the numbers. So this is the number of people that develop breast cancer age 50 to 59 over the next 5 years per 1,000 women. So 26 per 1,000 women aged 50 to 59 will develop breast cancer over the next 5 years. If they have a body mass index of 30 or above, then an additional 24 on top of that 26 will develop breast cancer. If they take combined HRT, an additional 14 will develop breast cancer. If they drink 2 or more units of alcohol a day, then there's an additional 5 cases. With estrogen-only HRT, there's just an additional 4 cases. And there are protective factors as well. So in women who do at least 2.5 hours of moderate exercise a week, there's actually 7 fewer cases of breast cancer over the next 5 years. And this is for the sort of general population. So, I mean, obviously, different people have different background risks of breast cancer, depending on their family history and genetics and various other things, which we look at on an individual case-by-case basis. So I'm just going to show you. Oh, all right. Sorry. Yeah. So the risk of breast cancer does increase with age and longer term use of HRT, but the dose of HRT doesn't make any effects. So it doesn't make any difference. After you stop HRT, the risk of breast cancer does go down over the next decade. And in women who are taking HRT below the age of the natural age of the menopause, which is 51, then you don't need to worry about the risk of breast cancer because it's not increased. You start counting from taking HRT at sort of age 50, 51. And again, it may be low. The risk of breast cancer, there's been some studies that show it may be lower if you use combined HRT that has natural micronized progesterone or digestone in it. Although the risk of breast cancer is slightly increased with HRT, the risk of dying from breast cancer is not affected. So the mortality is not affected. And I think it is worth remembering that breast cancer is a treatable condition as well. Very treatable. There's lots of, I mean, obviously the treatments are not particularly nice, but it is immensely treatable. So this is another way of putting risk. This is relative risk. So this is a study that some people put together in 2009. It's a little bit old, but I just thought I'd show it to you because it's another way, and that sometimes journalists latch onto and they say, well, HRT has got what is 25% extra risk of breast cancer over baseline. So baseline is 1. So you can see from this on this particular study, it thought that estrogen only had a slightly lower risk. But look at the other things that are on here. So the other things that people have studied that increase the risk of breast cancer, relatively speaking, this is not absolute figures, are things like eating grapefruit, taking antibiotics, being an Icelandic flight attendant, and using electric blankets. So it's just, I put it in a little bit tongue-in-cheek, really, but it's just to sort of show that it makes a difference as to whether you sort of look at risk from the point of view of it being a relative risk compared to something else, or the absolute risk in terms of numbers. And then here's another way of putting the figures. So this is sort of turning it on its head, really, and saying, well, what's the risk of not developing breast cancer if I took HRT for the next 5 years? So this is per 100 women. So if you took 100 women aged 50 to 59 over the next 5 years that weren't taking HRT, 97.4 of them would not get breast cancer. If they took combined HRT, 96 of them would not get breast cancer. And if they took estrogen only HRT, if they could, because they hadn't got a uterus, then 97% of them wouldn't get breast cancer. So I hope that shows you different ways of how risk can be discussed. And a lot of people ask, well, how long can I take HRT for? Well, there is no evidence-based cutoff point, so there shouldn't be any arbitrary limit put on how long people should take HRT. And certainly women who have a premature menopause, early menopause, should take HRT at least until the age of 50. And we recommend, the British Menopause Society guidelines recommend that every year people are on HRT, they should have an annual checkup and just go through the pros and cons and on an individual basis. Sometimes people stop it and then you might get some symptoms for a few months. It's worth maybe trying to stop, if you want to stop it, try and stop it for several months, because the symptoms, there's a good chance the symptoms might settle down. But people who do decide to go back on it or continue therapy are those whose symptoms don't settle in a few months after stopping, or who maybe have got a high risk of fracture or have got symptoms and alternative treatments are not appropriate. Okay, so is there any questions on that? Just questions for clarification on that section? Anything anybody doesn't understand? Or
could I ask something?
Mm-hmm.
Does the higher the dose of HRT increase the risks? Because there's been traditionally a thought that you could only go as high as the doses that the patches come in. But now, you know, through my learning about HRT and going through like Louise Newson and that, they're prescribing much higher doses. I'm on 150.
Yeah.
And my symptoms are just all back. I've still got brain fog. I'm still having terrible night sweats. And I'm thinking, well, why am I even bothering taking it? Because it's not doing anything. But GPs are reluctant to go any higher.
Yeah, I mean, at those sort of levels, sort of talking on a general in a general way, I personally think it's useful to have a blood test done to check the estradiol level to see what it is, and so certainly at the in terms of transdermal preparations, the risks of deep vein thrombosis and stroke at standard doses are not raised. There is some evidence that even at higher doses, the risks aren't raised, but there's not as much evidence. But the evidence is starting to accumulate more. And as we said, there's no increased risk of the dose doesn't affect the risk of breast cancer. So you don't need to worry from that point of view. If people have to take combined HRT, then you do need to think about whether you need to increase the progestogen dose as well to make sure there's enough protection for the lining of the womb.
Okay, so it is okay to go above the dose if it's prescribed, because I'm on micronized progesterone anyway, so I take that continuously.
Yeah, but certainly for higher doses of estrogen, I think you do need to have a discussion about increasing the dose of progesterone as well, just to make sure you're getting enough endometrial protection.
Okay, thank you.
Okay. Do you need to wean off HRT if you've been on it for over 4 years?
You don't have to wean off it. You can just come straight off it, or you can wean off it. I personally, I started HRT when I was about 46, because that's when my symptoms were like my brain fog and sort of low mood was worst. And then actually recently I stopped it in November, but I was on a patch and I cut it down. I cut it in half for a few months, and then I cut it in a quarter for a few months, and then I stopped altogether. So that you can do either.
Okay, brilliant. I was told age 47 I could only have HRT for 5 years. Can GP decisions like this be challenged?
Absolutely, yeah. There's no arbitrary cut-off point.
Okay. I'm just looking above from the previous, if there was any previous
there's one question. Can you have estrogen only if you have a family history of breast cancer?
That's a good one.
It is a good one. It's difficult to give individualized advice, but I mean, a family history of lots of us have a family history of breast cancer. I mean, I've got a family history of breast cancer. It depends what the family history is as to what your background risk is, and then I think it's about having a discussion with your healthcare professional about sort of weighing up the pros and cons of the family history risks and the small HRT risks and other risks that there might be. Yeah. Okay.
Just said mum and sister. That's the family history behind that.
Yeah. So I mean, it's worth having an individualized talk in that situation with your healthcare professional to talk about the pros and cons, because different people will accept different levels of risk, you see, as well.
Yeah. Thank you. Just a couple more. Are patches more available now? I said I've been unable to get them. I'm also experiencing bad spots again since I went on to, is it Clyofem? It needed a higher level of estrogen as flushes came back. Is there any way around this?
Yeah, so patches are back available, yes. If you go on, if you're interested to know what is available, if you go on the British Menopause Society website, they have a news section at the front, and on there, if you have a look through, there's several articles about what is available, in quite detail about what is available and what's not available. So you can challenge if there's any issues there, you can challenge whoever's prescribing it.
We'll put the website on the chat as well later.
Yeah.
To kind of access that. Two more, I think. Would I need more progesterone if I have a Mirena coil in situ and I increase my estrogen dose?
No.
Right. Well, and then I think we've got the last one.
It gives enough progesterone. Yeah.
Right. Okay. Thank you. And then one more. I have had conflicting information about HRT, as my mum had TIAs in her 70s and died of a stroke in her 80s. I've recently started on combined HRT. Is my risk increased? It
depends whether it's oral or transdermal, basically. And risks of TIAs, my mum had TIA, so did my grandma. And people have TIAs in their 70s and do die of strokes in their 80s. So I think that shouldn't really have any effect on your sort of personal risk of HRT. I know I'm not supposed to be going into personal details, but yeah, I would say transdermal would be preferable in that situation, rather than oral, because transdermal doesn't increase the risk of stroke.
Right, brilliant. Thank you. I think that's it for now.
Okay. Right. So next bit then, last bit. All right, hang on. So testosterone. So this was in the NICE guideline in 2015. So if HRT alone isn't effective for loss of sexual desire, then testosterone gel can be considered. So there's various ways of giving it. There's the picture of the pink thing, that's Androfem. It's actually licensed in Australia. You can get it from two pharmacies, two private pharmacies in the UK, through individualized prescribing, or you have to have off-license testosterone, otherwise that's licensed in men. So the one that I usually prescribe is testosterone gel. That's the top sachet there, and that sachet there is a dose for a man for a day. But obviously we don't need as much, so we use. That is a pea. That is a picture of a garden pea. And so that's what we use, what we call the P scale, which is about 5 milligrams a day, so that you make one sachet last about 10 days. Just fold it over and pop a paper clip on it. Yes, it is a bit Heath Robinson, but it's the only thing that we can do at the moment, because there was a patch, there was the Intrinsa patch, but it got taken off the market because they couldn't make any money from it. It was perfectly safe, but it was quite expensive, and it never made it onto to drug formularies, and they took it off the market because of funding issues. You have to have it. You have to have it monitored. A lot of GPs, somebody's put in the chat. A lot of some GPs will prescribe it. They're quite happy to. I mean, you can. Again, it might be worth us putting there's a primary care women's health forum, which again you can access. Anybody can access it, because I've been able to get onto it, and I'm not a member. And that has got guidelines for GPs on how to prescribe testosterone. And there's also an international consensus statement as well, which I follow. So you do have to have it monitored. So you do have to have your testosterone level checked before you start, and then after about 6 weeks, and then every 6 months, because just in case the levels go a bit too high. So you just have to have them monitored. The gel, different gels. So estrogen gel goes on the shoulders and inner thighs. Testosterone gel, it depends which one you use. Different ones advise you put it in different places, but it's usually sort of thighs, lower tummy. Right, and Tibolone is an oral tablet, which it's a synthetic HRT, but it's got estrogen properties, progesterone-like properties, and androgen-like properties in one oral tablet. So it can be very helpful for people with loss of desire, and it is licensed to help with loss of desire as well. So somebody's just asked about side effects with testosterone gel. Very few side effects on the standard dose, as long as you don't take too much. Occasionally a bit of acne, a bit of increased discharge, but very few side effects. You're not going to grow a beard or anything, or your voice isn't going to change or anything like that. We're just sort of giving a little tiny physiological level. So a lot of people, a lot of a common question I get asked is, I can't take HRT, is there anything that can help me? But when you delve into it, often HRT is not necessarily contraindicated, because there's very few absolute contraindications to HRT. So these are the obvious ones. So undiagnosed abnormal bleeding, known or past or suspected breast cancer, and other estrogen dependent cancers, current or very recent deep vein thrombosis, current or very recent heart attack or stroke until the body's recovered, very severe liver disease, and porphyria, which is a rare disease. So non-hormonal medications. So there's one license. It's called clonidine. It's been around for donkey's years. It's an alpha blocker. It used to be used for blood pressure, so it can lower blood pressure, and I think it might be also been used for migraine prevention. But it's also licensed for the use of menopausal hot flushes, although it occasionally works, but I think it more often doesn't work than work. And obviously you just have to monitor blood pressure. It's taken twice a day, and you have to gradually increase the dose and gradually reduce it as well. And then there's some other off-label medications that can be very effective. So low dose SSRI and SNRI antidepressants. So that's things like venlafaxine, Prozac, fluoxetine, sertraline, citalopram. They have been shown to reduce hot flushes and sweats by about 60%, and they can also obviously help with mood and anxiety. So that's them. Although there has been at one point, I think a lot of people were offered those before being offered HRT, but really, if people can take HRT, then HRT would be more effective treatment for all the menopause symptoms, because obviously all medications have side effects. So with SSRIs, SNRIs, sexual dysfunctions is quite a common side effect. Also, sort of rashes, gastrointestinal upsets. Gabapentin, pregabalin, has also been shown to help with flushes and sweats, but that's become more difficult to take because it's a controlled drug now, so prescribing is a bit more tricky. In my personal experience, anecdotally, in the few people that I've tried it with, it can be good if people are not sleeping very well, because it can make people quite sleepy. But a lot of people don't like the sort of the sedative effect of it. And then oxybutynin has been used for excessive sweating. It's a similar sort of drug that's used for bladder urgency. So that can be useful in certain situations as well. Okay, so just to move on to vaginal and bladder symptoms. So often a lot of women don't actually realise that these have got anything to do with the menopause, because they sometimes come on sort of many years after the hot flushes and sweats have stopped. But quite a significant number of women do get bladder symptoms, so urgency, recurrent urine infections, vaginal dryness, vaginal soreness, and painful intercourse. So, but it is eminently treatable. It's not something that you need to put up with. So there's lots of lubricants and moisturizers that are available on prescription as well. Sort of trendy ones at the moment are a company called Yes, and also Hyalofem can be very helpful. So you can take estrogen just vaginally. It's very safe. There's different ways of taking it. So I've got a little, I'll show you here. This is an applicator that's for vaginal estrogen cream that you screw onto the end of a tube of cream. There's pessaries as well. I'll show you a little dummy pessary here that, if I can open it, that you just pop in like so. And this is like another applicator one, which is a little vaginal tablet that goes on the end. And there's a ring here as well. This is a ring that you squeeze together and it pops into the vagina. You wear for three months. So that estrogen, it doesn't go through the rest of the body, or very, very small amount does. So you'd have to take it for a whole year in order to have the equivalent of 1 day's worth of oral HRT. So it's very safe and very effective, and even people with breast cancer can use it as well. Ospemifene is an oral tablet that has been shown to help with vaginal and bladder symptoms as well. And I think the benefit with ospemifene is that the license includes women with breast cancer once treatment has been completed. And vaginal DHEA, dehydroepiandrosterone, is a precursor hormone. It's converted in the vaginal wall to estrogen and testosterone and other androgens. And again, that's it's just another tool in the toolkit. Other things that can sometimes help with vaginal and bladder symptoms are psychosexual therapy and pelvic floor physiotherapy, but we haven't got time to go into that just any more detail just now, looking at the time. So the future, so the research at the moment, there are a group of drugs called neurokinin 3 receptor antagonists. I know that's a bit of a mouthful. So basically that it's a modulator of the secretion of the hormones in the pituitary gland. So there's phase 3 studies of those going on at the moment. And a couple of years ago, you might have heard in the news a surgical procedure where people were having a little wedge of their ovary removed, which would then be frozen and then reimplanted at a later time. This is actually a procedure that's used. It's been used for a long time anyway for people who are undergoing treatment for cancer, so for younger women who might want to have children in the future. But more recently, more research has started to be done on it being an option for delaying the menopause. But it's very, very early stages, and if it was to take off, it would need a lot more research and comparison to other management options such as HRT. Okay, so I'll quickly put the quiz answers up for your interest, and then if anybody's got any questions, we can just hopefully answer those. So I'm just copying the quiz answers. Thank you to those of you who've taken part, and I'll just pop the link in there. So if we just open that quickly. quickly. I don't have permission to view the responses.
Oh no. Do you want me to read them out?
Oh no, I've got it. It's all right. So great. So in which year was HRT first approved for use? Spread of answers. It was actually 1942. Just out of interest. So which of the tissues below contain estrogen receptors? Yes, all of the above. So skin, brain, lungs, along with a lot more. And what are helpful for managing recurrent urine infections? So all of the above, maintaining good hydration, vaginal estrogen, and some people, find that taking antibiotic prophylaxis helps as well. So brilliant. So
there's a few questions that were kind of going on during that and during the. Do you want me to say them now?
Yes, I'm just putting that slide up of resources just for information. Yeah.
Fantastic. One came on when you were talking about testosterone and asking whether or not can all GPs prescribe this.
So there's no reason why they can't. A lot of them, many of them are happy to, but not all of them, because it's off-label. And I did actually go along to the. So I think the problem is that the local formulae, the local guidelines say that you should get a specialist opinion, which locally here means having on the NHS having an appointment up with the gynaecologist or going to Derby or Sheffield. I did go along to their to their meeting and try and get it changed so that it could be so that the GPs. It would say that the GPs could just prescribe it, if they followed certain guidelines. But unfortunately, that didn't get into the most recent formulary. So maybe it will in the future. Let's hope so. But some GPs are happy to, and some prefer people to be referred for a specialist opinion first of all. But to be honest, it's not rocket science. And as I said earlier, the Primary Care Women's Health Forum have got very clear guidelines for GPs on how they can prescribe testosterone safely, and there are international consensus guidelines as well that people can follow.
Thank you. Another one, I don't know if probably have touched on this, but what the side effects are there with the testosterone gel, please?
So side effects are very minimal. So very few people get side effects. So the things that people might find are a slight increase in oiliness of their skin, and maybe a little bit of extra vaginal discharge, maybe slightly, sometimes a little bit more irritable initially, but the dose can be modified. But there's certainly in the studies, if you use a physiological amount, just a very small amount, and you have it monitored, the level monitored, then it's very safe.
Right.
Yeah. I mean, it's only been studied for a couple of years, so that in terms of long-term use, sort of the evidence is for a couple of years use. Yeah.
Well, thank you. Got one here. Can you take HRT if you have fibroids?
Again, it sort of depends on the extent of the fibroids, and but yes, generally there's no reason why not. Fibroids can grow under the influence of estrogen, so they do need monitoring. It's difficult to answer that for everybody. It's difficult to generalize, but yeah, there's no reason why. It's definitely not an absolute contraindication. Yeah. And
just as a side question from that, then, if you had someone who, say, had polycystic ovaries, I know I don't think they necessarily go over time. And if you had HRT or testosterone, would that have negative side effects potentially?
With polycystic ovaries, well, certainly not a contraindication to HRT. I mean, obviously, there's polycystic ovaries can have different effects in different people, so it's difficult to generalize. But it's not, it's not a recognised contraindication to HRT.
Well, thank you. Can I take vaginal estrogen along with HRT patches?
Yes, you can take vaginal estrogen. So sometimes HRT on its own, if people have got particularly severe genitourinary symptoms, then sometimes the HRT what we call systemic HRT, which is like oral or transdermal HRT, sometimes that's not enough on its own, so you can take vaginal estrogen as well. Yes.
We've got another one here. Can you take tibolone for PMDD/PMS, and if you still have periods?
So tibolone it's a period-free HRT. So it is designed for people who've gone through the menopause. However, some people, so some people with very severe PMS, PMDD, they might have tried SSRI medication, they might have tried high dose estrogen, but still have the symptoms. So the sort of next step is to be referred to a gynecologist to try what's called a gonadotrophin analog, which basically is a tablet which stops the pituitary gland producing the hormones that underlie the menopause cycle, the menstrual cycle. So it's a bit like creating a sort of menopausal state. The problem with that is that that's fine on a temporary basis. It gets rid of the PMS and PMDD, because PMS and PMDD are to do with the sensitivity to the side effects of progesterone, which is produced in the second half of a natural cycle. So if you take a gonadotrophin analog to block your cycle, you can get menopausal symptoms, and that can affect your bones as well. So it's not recommended that you do that long term without some add back HRT, and often the HRT that gynecologists use is tibolone. So in that situation where people are on a gonadotrophin analog and then have tibolone as well, and one of the other reasons why the gynecologists give tibolone is that sometimes for very, very severe PMS or PMDD, people consider having their ovaries removed. But once you have your ovaries removed, you will go into the menopause. And so trying out using the gonadotrophin analogs first can be, and then having add back HRT, often in the form of tibolone, can be a way of trying out and seeing what life might be like after having one's ovaries removed.
Right, thank you. That's interesting. Another one here. There seems to be many benefits of HRT, such as reducing risk of diabetes, etc. Then why are GPs not prescribing it readily? I guess.
Yeah, well, we sort of talked a little bit about. I mean, I've got my own I've got my own sort of personal theories. I mean, a lot of it, I think, is that when you train as a doctor, the sort of the textbooks that you read are sort of like 10 years behind in terms of the studies they've got. So they've got all the studies that were produced in the noughties still in them. And the other thing is that the education on the menopause for GPs is minimal, very minimal. I mean, the education for women it is minimal. And the other thing is, I think, because generally, if you go to see the GP, you get 10 minutes, and that 10 minutes is probably long enough to sort of explain how the symptoms are affecting your life, let alone thinking about, going through all the options for treatment and weighing up the pros and cons. So I think it's very difficult I think it's a difficult situation. So I would certainly recommend, you look up some of these websites, go on. There's a lot, obviously there's Louise Newson's, if reading is not your thing and you prefer podcasts and things, I mean, she's done them. And there's also videos on the British Menopause Society website. and find out as much as you can about it, so that you feel nicely informed when you go to your GP. You can, you can then feel that you're in a better position to talk about what you feel is best for you.
Yeah, brilliant. Thanks, Amanda. One here, are there any menopause clinics locally?
Well, there used to be until it was decommissioned, because I used to run it. So I do run a private service locally. There is one in Sheffield. There's an NHS one in Sheffield, and I think there's one in Derby as well. Yeah. There is possibly talk of something being developed. Hopefully there will be, because it's very important. Yeah.